Please note that PMSF's resources should not be used as medical advice. These resources are intended to be guides that should be used in discussion with medical professionals who know your child. Our resources are just one set of tools available to you to help you and your child's team as you make medical decisions. You know your child best. Hi there, my name is Carla D'Imperio, and I'm the Family Support Specialist for the Phelan-McDermid Syndrome Foundation. I'm so glad that you've joined us today for our new family webinar, which actually contains a lot of really great information for all of our families. A little bit about myself. I've been working for the Phelan-McDermid Syndrome Foundation for over 2 years now in this role, and I'm mom to Matthew, who's my 9-year-old son who has Phelan-McDermid syndrome. I have 2 other children, and Matthew's my middle child. My husband, Michael, and I live in Tarpon Springs, Florida with our 3 kids and our 2 dogs. So it's a little bit busy around my house, as I'm sure you all can imagine. I'm looking forward to spending this time giving you a tour of our website and our resources and hopefully answering some of your questions. So let's go ahead and get started. Please join me and follow along at pmsf.org. I can't really say enough good things about our website. There is just a ton available, a ton of resources. And I think that it's important for families to understand what's out there and how to access it. So a lot of what I'm going to show you, I would encourage you to, bookmark it, download the files, upload them if your child has MyChart, upload them to share them with your child's medical professionals. Also you could print them out and bring them along with you to doctor's appointments. A lot of these resources are really meant to help you educate yourself so that you can educate your child's medical professionals and be a better advocate for your child. Okay, so our homepage, if you scroll down, it's always going to have our latest blog posts at the bottom. So you can kind of see what's been shared recently. That's all going to live here on the homepage. We have some partners listed as well and our sponsors. If you look at our pictures on our website, they're all of Phelan-McDermid syndrome families and of our kids. So we don't use stock photos. Anybody that you see on our website is someone who's part of our community. If you're interested in sharing pictures of your own family, I can send out our link to upload those pictures. We're always looking for, more representation of our families and of individuals with Phelan-McDermid syndrome. So our website is broken down by the 3 pieces of our mission at Phelan-McDermid Syndrome Foundation, which is Connect, which has to do with family support, Care, which is advancing medical care and clinical care for people with Phelan-McDermid syndrome, and then Cure, which is driving towards treatments and cures for the disorder. So that's kind of how the top navigation bars are organized. And then, this is information about us as a foundation. Our blog posts, news and updates, and then ways to get involved is also here as well. There's also our join button. So if you know someone who is a friend or family that wants to support you and your family and wants to be on our mailing list, they can go ahead and join as well. It's free to join our membership at this time. And then the donate button, of course, we rely on donor dollars to operate. So we always encourage people supporting us in that way as well. So under family support, that's probably how you found us was found out about this webinar as there's information listed about our first 100 days program and our support programs. We have our caregiver support groups. All of that is kind of listed there. So I'll come back to some of that. But what I really want to do is dive into the care section, which is, again, advancing and supporting medical and clinical care for our kids. And we're going to start with the tab that says, what is Phelan-McDermid syndrome? So a really simple definition of Phelan-McDermid syndrome is given here. It is Phelan-McDermid syndrome. We hear sometimes people pronounce Phelan, and we have a whole Phelan Lucky campaign, so that can be a little confusing. But Dr. Katie Phelan, that's how she pronounces her name. And so we do have that. It shows how to pronounce it here. It's a rare genetic disorder involving chromosome 22 that can affect many critical functions of a person's body, from learning and communicating to eating and sleeping. So there really can be a variety of impacts of this diagnosis. There's medical pieces, medical components to it. There's behavioral and developmental components, and then there can be psychiatric components as well. So it really can affect all aspects of a person's life, which in turn does, have a big impact on the family and what the family's life together looks like. There's some Q&A or FAQs on the side as well. Those kind of open up. So what this means in terms of the genetics, it can vary, but you're talking about a difference on what's called the Q arm of chromosome 22. So every chromosome has a P arm, which is the short, it's called petite arm, and then the Q arm is the longer arm of the chromosome. For Phelan-McDermid syndrome, we are talking about that long arm. So it's 22 means chromosome 22. Q is the Q arm, and then 13 has to do with the location on that Q arm. So the higher the number, the further towards the end of the chromosome. So we're talking about the closest part to the end of the chromosome. Many individuals with Phelan-McDermid syndrome have a deletion of that end. It's called a terminal deletion on chromosome 22, which can vary in size from very small and only affecting those genes at the very end of the chromosome to about 9 megabases, which means 9 million base pairs of DNA. So there can be a big variety in deletion size. And then in addition to those deletions, we also support our families whose diagnosis is a variant, which means that something on SHANK3 is in the wrong order, or there's something very, very small missing. And that SHANK3 gene is one of those genes near the very end of the chromosome. So if you have a difference on SHANK3, or if you're missing SHANK3, all or part of it, then that's going to be a Phelan-McDermid syndrome diagnosis with some exceptions. But generally speaking, that's what the diagnostic criteria would be. Again, would be a difference on SHANK3 or a missing part of or all of that SHANK3 gene, which is at the end of chromosome 22. So these are some downloads. There's a one-page summary that's really nice about Phelan-McDermid syndrome that would be good to share, with family and friends, people that have questions about what is this new diagnosis that your family is managing. We have a genetics overview of Phelan-McDermid syndrome. So I'm not going to open all of these right now, but I want you to know that they're available. And then this goes to our genetic counselor resource page. So if you have more questions about genetics, you can really dig in here. We also do have a free genetic counseling program. So if you're facing a long wait for genetic counseling, or if you still have questions after receiving genetic counseling, because oftentimes, geneticists and genetic counselors don't have experience with Phelan-McDermid syndrome. So if you fall into either of those buckets, then please reach out to me. We will then get you set up with our genetic counselor that we contract with. We work with Mount Sinai Seaver Autism Center in New York, and we have a wonderful genetic counselor that we work with there who sees one PMSF family per week. Her name is Tess Levy. She spoke at our conference a few months ago, and she's just amazing. So she's someone who could meet with you. That program is at no cost to our families. So if that's something you're interested in, be sure to email me, and you'll be sending me your child's genetic report. And I might have some questions for you as well. I just like to kind of give this overview, and then we'll get into some of the resources. So this just shows the chromosomes. This is where we're talking about the one chromosome that has to do with Phelan-McDermid syndrome, and then zooms in on that end I was talking about, the Q arm, and zooms in even more onto SHANK3, which is that gene close to the end of the chromosome. Sometimes with other rare diseases, you might be familiar with seeing chromosomes shown as an X shape. And that's because those rare diseases would have to have a difference on both the chromosome that comes from the mother and the chromosome that comes from the father. So they do show both of those chromosomes together make an X. So you might be familiar with seeing that in other organizations. And the reason that we don't display our chromosomes like that and ours are aligned is because you only need to have a difference on one of the chromosomes to have Phelan-McDermid syndrome. If you have an anomaly or a missing SHANK3 gene on both chromosomes, then that would not be compatible with life. So our population, there's only one of the two chromosomes for chromosome 22 has to be affected. So that's why you see lines rather than X's. Okay, we talked all about this. We talked about SHANK3. Is Phelan-McDermid syndrome inherited? Most times this is a random, it's called a de novo change, and it's a genetic change that happens randomly, usually at the time of fertilization of the egg. So it is not generally inherited. There are cases where it is, and depending on your child's genetic report, you might have received genetic counseling recommending that the parents are tested as well. So if that's something that you have questions about, please let me know, and we can make sure to get the genetic counselor to help you answer those questions. But most of our cases are de novo, random. Okay, so this gets into some of the signs and symptoms. They really do vary in severity from person to person. It can look very different depending on the person. Some have, very little medical involvement and lots of behavioral and developmental issues. Some have both, pieces. So it really varies. We don't yet know or really truly understand the link between the genotype, which is the genetic situation, and the phenotype, which is how those symptoms and features play out. We don't have a full understanding of that yet. So there's no way for us to say, okay, my son Matthew has a 7.1 megabase deletion, and that means this about his ability to talk, or will he, be able to do certain things on his own? We don't know that. So really what you want to do is support your child the best you can. And, our kids do amazing things. My son surprises me every day with what he's capable of. And there's really no way to predict what those outcomes will be like. Some things that we can have a better understanding of are things like with larger deletions, there's more of a chance of some of those kidney abnormalities, which are recommended, to be screened for with the diagnosis. Some of our kids with those larger deletions also have those very similar clinical features, like the long eyelashes, the round nose. My son definitely has that sort of look to him, those mild dysmorphic features. So those are some of the things that we can see with the size of the deletion, but we're still learning so much more about genotype phenotype connection. That's really one of the goals of the natural history study, which there's, a lot of data is being collected from our families and our individuals with that study. So this goes through some of the symptoms: moderate to severe intellectual disability, speech delay, problems with speech, muscle tone, lower weak muscle tone. This is a big one. This is one that is very, one of our most common features is hypotonia. Sleep disturbance is a big topic in our community. Poor feeding, difficulties with toilet training, seizures. About half of our population will have a seizure of some kind in their lifetime, whether it's one seizure or, ongoing seizures. And then about a third of our total population will have an epilepsy diagnosis. And then within that cohort with epilepsy, we do have a smaller group. We don't really have an exact number that has, intractable, untreatable seizures that are very difficult to manage. But that is a pretty small number within our population. There's a lot of behavioral challenges. Those can often be linked to GI issues. I find that a lot with my son when he's having issues with his gastrointestinal system. He has more difficult, challenging behaviors, and then decreased perspiration and heat intolerance, lymphedema. Those are also issues as well. And gastrointestinal issues are definitely a big one. You'll hear people in our community talking about poop. It's a big topic. For Matthew, we work really hard to keep him going to the bathroom regularly, and then we see he's generally happier, and it's a way that we can kind of control some of his more challenging behaviors. Medical issues associated with PMS, aspiration's a big one. Autism and autistic-like behavior. Sometimes you'll hear people in our community talk about how their child, they struggled to get an autism diagnosis for their child because their autism looked different than what kind of the classic presentation of autism is. So, a lot of times our kids make really good eye contact, or they're smiley, they're happy, they're interactive. But that doesn't mean they don't have autism. So when you're getting an autism diagnosis, seeking that diagnosis, you want to make sure to see a medical professional who looks at it, from the big picture of all of the different domains that can contribute to an autism diagnosis, not just whether they're making eye contact or smiling. Reflux, what else? Chronic diarrhea, we talked about some of these already. Seizures. This is kidney reflux, vesicular reflux. So that's one that, you've probably been told to have your child's kidneys screened. That's important to do, shortly after diagnosis. And then some of these mild dysmorphic features that I mentioned a little bit, the eyelashes aren't listed here. I'm not sure why, but the toenails, people talk about their kids have these flaky toenails. There's some mild facial features, which there it is. That's where the eyelashes are, the long, thick eyelashes. So it's just interesting, to see this and sort of think, oh, wow, my child has that. That's amazing. We really, found this community that makes sense for us. I hear that a lot from families. So you might enjoy taking a look through some of these. In terms of how common Phelan-McDermid syndrome is, we estimate it's about 1 in 10,000 people. However, our actual numbers of diagnosed are, much smaller than that, and we believe it is really underdiagnosed. We currently report about 3,600 individuals worldwide. And when you join our membership and you put down that you have a child with Phelan-McDermid syndrome and their name and everything, that's, then they're counted as one of those individuals. About half of those individuals are in the United States. And really, we don't believe that's because it's more common in the United States. It's an access to testing, access to medical care and genetic testing issue. So you'll see a lot more diagnosed individuals in the US, Canada, Europe, Australia, and then it's really underdiagnosed in other areas. We're growing. We get about 3 new families, new members every 4 days. So we're growing at a really rapid rate as genetic testing gets more sophisticated. And like I said, about half of our families are in the US. We have over 100 families, almost 200 families now in California, about close to 150 in Texas and over 100 in Florida. Those are our biggest states, not surprisingly. It's always diagnosed through genetic testing. So the only way to get a Phelan-McDermid syndrome diagnosis is to have genetic testing done. The different genetic tests will show different information, and I'm not going to get into that right now, but if you have questions about genetic testing, let me know, and that's something that we can, if I can't answer your questions, we can definitely have you talk with the genetic counselor. All right, so I'm going to stop there for this page. This is a nice resource if you're, curious about genetic testing. So I think that kind of covers everything on this page. I am going to move on now to our medical issues and clinical care page. One of the things that makes us unique as a foundation, and that I think is pretty special about what we do, is that we have a wonderful medical advisory committee made up of experts and parent experts. So they're all medical professionals, and about at least half of them are parents of individuals with Phelan-McDermid syndrome. You can find out and learn more about our medical advisory committee here under Foundation. If you go to leadership, you can learn about everybody in our foundation here. But if you scroll down, there's lovely pictures of everyone. We have our scientific advisory committee, and here's our medical advisory committee. So you can see that these are amazing doctors who they are there to help, troubleshoot if there's anomalies or questions that come up that can't be answered by the child's clinicians. And then they also worked on our clinical consensus guidelines along with, a lot of other people. And they do issue our medical advisories. So if there's some kind of a trend or development in the community that we need sort of an official communication about, our medical advisory committee will go ahead and put that together for us. So those are listed again under medical issues and clinical care. And we have 6 medical advisories. I'm going to highlight 2 of them that are really important for new families to be aware of. The first is the medical advisory related to anesthesia medications. the takeaway is that some medications used in anesthesia may exacerbate symptoms in our kids. And it goes into outlining specifically which medications those are. And the types that should be avoided are called neuroleptics, which are also known as antipsychotics. So those medications are sometimes used in general anesthesia, and with Phelan-McDermid syndrome, they really should be avoided if possible. Other takeaways are that adverse effects appear to be quite rare. Most people don't have complications from anesthesia. Propofol is well tolerated in general. And then benzodiazepines like lorazepam, which is also called Ativan, or diazepam, which is called Diastat. Those are also commonly used during anesthesia, and they are well tolerated. They can have some adverse reactions, but those diminish quickly. So my son, for example, when that diazepam, which is also called Valium, when that starts to wear off, he gets very agitated and confused. So, but that goes away and then he's fine. So really the one to avoid is, again, neuroleptics, also known as antipsychotics. So if your child is having a sedated procedure, dental work, surgery, a sedated MRI, anything like that, you want to make sure to share this letter with whoever is administering and making decisions about the anesthesia so that they're informed about these guidelines. This one is about reaction to some psychiatric medications, and there is, overlap with the letter I just shared with you. So if we go into this, it talks about how SSRIs, which are a specific class of drugs that are often used for depression and anxiety, they actually can cause a high rate of emergence of manic symptoms and worsening agitation. So they can do the opposite of what they're supposed to do in individuals with Phelan-McDermid syndrome. Now, remember, they can do that. It's a guide. This is a guide. This is meant to give you more information to help you make a decision with the doctor. This is not medical advice. This is not saying strictly black and white, no, don't use these, yes, this or that. It's really, this is something that can happen. Discuss it with your medical provider. Share this letter, share the information, and make the best decision for your child. Again, about antipsychotics. So it talks about here how treatment with antipsychotic medications appears to be less well tolerated, with an increased risk of symptoms of catatonia and higher rates of other associated side effects. So those antipsychotic medications can definitely cause problems in our population. Some of those times can be very difficult to recover from. So really, those should be avoided with exceptions. And again, as discussed with your child's medical professional. It goes into a little more, about using caution, recognize these are trends. There are always exceptions. So say your child is on, an antipsychotic for behaviors. This is not telling you to go pull them off that immediately and stop taking. No, this is a discussion point with the doctor. Share the letter with the doctor and make a decision about what's best for your child. You know your child best. So those are our medical advisories. There's, like I said, there's 6. So you're welcome to, look at the others in more detail at any time that you'd like. We're very fortunate to have 3 sets of clinical consensus guidelines, also called clinical care guidelines. And basically these are documents of varying lengths and structures that were put together by large groups of experts to help with the management of the clinical care of our population. So these are resources that families can look at. These are resources that doctors and any medical professional, therapists should be looking at to help direct and manage the care of individuals with Phelan-McDermid syndrome. We're fortunate that we have 3. Like I said, we have 2 sets that were released in 2023. One of those is called the European guidelines, so I'll get into that. We have the international US guidelines. So those are 2 sets made by 2 different groups of people. And then we have an old, shorter version, kind of the old school, the OG clinical consensus guidelines from 2014, which is a great 1-pager, still relevant, still helpful to share. So I'll show you all of those. I'm going to go through them from the perspective of epilepsy, seizures, neurology to kind of show you and compare what each of those looks like from that lens. So you can think about, maybe you have your child has GI issues or behavioral challenges or whatever the case may be, but you would go through them and use them similarly. So if I'm thinking about, we're going to the neurologist and my child, maybe they're having seizures, we're going to have an EEG and start to look at that. The first thing I would want to do is pull the relevant guidelines and share them with the neurologist ahead of the visit, hopefully, so that they can sort of look at and peruse and start to learn about what neurological issues could look like in Phelan-McDermid syndrome. So there is a synopsis of the European guidelines here that sort of summarizes everything. But what I'm going to pull first is this one from the European Consensus Guidelines on Epilepsy. So that's where I would start if I was thinking about, again, from this perspective of seeing a neurologist. I'm going to open it up and show you that, like I mentioned, the European guidelines break it down into topics. So this one's specifically about epilepsy, but there's a bunch of other ones as well. I'm going to open this epilepsy guideline up and you're going to see it's very dense. It's, a scientific publication. So it's not really your light beach reading, but it's important to be familiar with. If you want to read all of them, great. If you want to just understand that it's available, that's fine too. Okay, so all of these are based on research available, all the actual publications and research that are available about Phelan-McDermid syndrome. So it has a lot of citations from where they're getting their sources and their information. So they're citing specific public publications and studies. And what is really important to be familiar with discusses all the results of the studies. But what I want to highlight for you is that all of the guidelines are going to have these recommendation tables in them. So this is table 1. I think it's actually the only table. It's the only table in this guideline. And this is really the heart of the matter. It's recommendations on epilepsy and Phelan-McDermid syndrome. So be alert for seizures and epilepsy, talks about EEGs. But what I want to highlight here is anticonvulsant treatment of epilepsy in individuals with Phelan-McDermid syndrome should be provided according to national guidelines. So sometimes people are surprised to hear that. Really, that's saying that there is not a special way at this time of treating epilepsy in Phelan-McDermid syndrome. The doctor, the neurologist, is going to refer to national guidelines for treatment of seizures, which often uses trial and error of seizure management medications, and can be kind of a long road to figure out the best solution. So I like to highlight that because people are not always aware that we don't have a special flow chart of seizure medications or something like that for our population. You would be treating it according to national guidelines. So keep that in your mind. That's the European guidelines. I'm going to go back to where we started. So here's all of the rest of the European guidelines, their consensus guidelines, recommendations, whatever, they're referred to as different things. There's altered sensory functioning, communication, sleep, organization of care, mental health, lymphedema, and then one to do with GI. So, spend some time on those. The best place to start with them is the synopsis, which what that does is shares all of those recommendation tables. Like I just shared that one table with you. So those are all there. And then if we scroll down, the US international guidelines, which were also released last year, it's one document. So the European ones break it down into a bunch of separate documents, I think 9. And the US, it's going to take all of those same topics and consolidate them into one really big document. So we'll open that up. I think it's about 40 pages long, 30 to 40 pages long. So, really does synthesize all of that other information. What's interesting about the international guidelines is if you look at the citations at the top, the people who contributed to it, there are parents who contributed. So it's not just medical and scientific professionals. They did take parent experience and caregiver information, which I think is really unique and interesting. So we're going to scroll down. It starts with genetics. as does the European clinical overview. The synopsis starts with genetics. Since we're a genetic disorder, that's often where it starts. There is discussion, what I just mentioned about phenotype, genotype, so you might find that interesting. Genetic recommendations, and I'm going to keep going because what we wanted to highlight is neurology, specifically around epilepsy, right? That was what I was sort of going from that point of view. So if we go down, this is our treatment recommendations table. So this is the corresponding table to what we looked at in the European guidelines on epilepsy. This is the recommendations on neurological considerations. So more general, because the other one was just about epilepsy, and this one's talking about all neurological considerations. However, if we go down here to epilepsy and EEG abnormalities, these bullets in here are going to be, pretty similar to what we looked at in that other set of guidelines. Specifically, I'm going to show you this one right here. So treatment and management of seizures in Phelan-McDermid syndrome are similar to standard practice. So this is a very similar conclusion and recommendation that we saw to what we saw in the European guidelines, where it said treat according to national guidelines. This is saying treatment is similar to standard practice. So it's another way of saying the same exact thing. So that at the end of the day, these two sets of guidelines are making the same conclusion. And I think that's important to highlight, that you can look at both of them and glean different information from different perspectives, but ultimately they're going to be aligned for the most part on the treatment and management of symptoms in Phelan-McDermid syndrome. Okay, so I'm going to close that out, but just know it's 30 pages long. There's lots of other topics in there, a lot to dig into if you're interested. I want you to be aware that these exist. And if I were you, I would, upload them to your child's portals, send them to your child's doctors, something for them to be, at least have on hand. If they're not going to spend the time reading it, to at least know it's there to look at with you during appointments, etc. Okay, so this is the OG, I like to call it the old school clinical consensus guidelines. It's a one-pager. Again, if we go through this perspective of neurology, you can see it's very simple. The other one is, tiny print and pages long, and this just gives a few bullet points, but it's important. The main ways neurology can be affected are through seizures, structural brain abnormalities, feeding difficulties, hypotonia, motor skill deficits, decreased perception of pain. And then underneath, these are the testing indications, so suggested tests. This is not like I have to go out and make these appointments right now and get all these tests done for your child. It's suggestions. It's a guideline to talk to your child's medical professionals about. So overnight EEG, we just tried to do one with my son. It did not go well. We lasted about 2 hours. Brain imaging, so that would be usually an MRI, head circumference monitoring, feeding therapy evaluation, and OT and PT evaluation. So, just giving a brief guidance on considerations for which tests to look at. I also like to look at neurology first because even though, PMS is a genetic disorder, you'll hear it talked about as a neurodevelopmental disorder because the genetics of Phelan-McDermid syndrome affect the neurology. So that gene we talked about, SHANK3, the point of that gene and what that gene does is code for a protein called SHANK3. And that protein is really, really important at the synapses of where the nerves come together and how they communicate. So if the nerves aren't able to communicate properly because they don't have enough of that SHANK3 protein, because that SHANK3 gene is not functioning, it has a pathogenic variant or a deletion, so it's non-functioning, then you are going to get these issues that are outlined here on this one pager. You're going to get seizures, hypotonia, motor skill deficits, all of those things. Those neurological manifestations are a result of that genetic issue. So just like to kind of get into that a little bit. Okay, so we have about 5 minutes left. I do have a couple more things I want to share, but that sort of taps us out on this medical issues and clinical care page. I do want to quickly go into a couple things on this is our page about neuropsychiatric issues. So some of you may already be familiar with, often with our adults who are recently diagnosed, they get their diagnosis because they've started dealing with these issues, but our population, as they reach their late teens and early 20s and adulthood, there is a subset, a cohort within our population that deals with some pretty challenging neuropsychiatric illness episodes. So we have a lot of support in place specific to that aspect of the condition. This is not something that affects everybody. I don't really know the percentage. I don't think we have that information, but it's definitely not something that affects everybody. However, we want you to be aware of it, and so that you can sort of identify if it's something that's starting to happen, and then also just to know what's available in terms of support. Okay, so one of the things that we have to support people going through these neuropsychiatric challenges is called our neuropsychiatric consultation group. They use what's called an ECHO protocol for how they structure their conversations and problem solve. And what this is a group of medical professionals. Some of them are on our medical advisory committee that I already talked about, and they will meet with your child's medical provider. So your child's psychiatrist, neurologist, primary care, whoever's the one prescribing medications, they will meet with that doctor. It does not involve the parent. It's a doctor to doctor structure. And they will help the doctor understand some of the specific considerations, such as those medical advisories I shared with you, some of the specific considerations around Phelan-McDermid syndrome. So that if that's something you're dealing with, you can submit, you can have the doctor submit the access form, which is at the bottom of this page. I will send you guys all these links. So down here, here's the access form. So that's how you would apply for a consultation. It has to be submitted by a doctor. And then it's usually about a 4 to 6 week wait for the doctors to have that meeting and consult with the committee. But what I want to show you is this information here, because sometimes these issues can be hard to identify, because if you're talking about someone who doesn't speak or someone who's autistic and has behavioral challenges anyway, it can be hard to identify depression, anxiety, mania. It can look different in our population. So we have some really nice descriptions written in these drop-down menus. So if you think your child, if their behavior changes and you're wondering, are we starting to see some kind of neuropsychiatric issues developing, I would encourage you to come to this page and utilize these drop downs to sort of think about, does this sound familiar? Is this what we're looking at? To kind of get ahead of it sooner than later. Okay, so if you're concerned about these changes, you can take notes, you can take video, talk to the doctors, and use this access form that I showed you to submit sooner than later to get a meeting between our doctors and your child's doctor. Keeping in mind those 2 medical advisories I mentioned, right? The antipsychotics and the SSRIs, because those can trigger some issues in our population. Okay, and then I really like to share our pharmacologic treatment guidelines. So this is like a medication flow chart pertaining to different behavioral and psychiatric issues in our population. So let me show you what this looks like. This is another excellent resource to share with medical providers. A lot of times as our kids get older, you can start to deal with some of these behaviors. And if families aren't seeing, maybe you're trying different interventions and not seeing results, and you're starting to think about medications. So this is a good resource to bring when you start having that conversation with doctors, if you start having that conversation with doctors. Not everybody uses medications or has to use medications to manage these types of symptoms, but if you do, please know that this resource is available. It's broken down into 6 pages that each are different topics. So page 1 has to do with attention deficit, hyperactivity, and impulsivity. Page 2 is irritability and aggression, and so on. I like to go to page 5 because it's my most familiar page in my life with Matthew, is sleep disturbance. So just to kind of show you how it works, you would start off seeing a doctor for a diagnostic assessment. They're going to ask you about sleep hygiene, which is things like blackout curtains, white noise, bedtime routines, all of that. Then they're going to want to rule out medical causes, restless leg syndrome. Are there other underlying causes? Then they would consider going down here and using these different medications to manage the sleep disturbance. So starting with melatonin, if there's a response, then you would use that and continue using that. If there's a partial response or no response, increase the dose. And then if there's still no response, you would move up to the next medication, in this case, clonidine or trazodone, and continue onward through the flow chart. So again, this is not meant to be medical advice where you're taking it and saying this is what we're doing, period. It is one piece of information to help you have an informed discussion with your child's medical professional. So please use it as a guide to help you as you make decisions with your child's doctors who know your child best about your child's treatment. So I'm going to stop there in terms of resources. I do want to just highlight for you really quickly 2 things. One is our genetic counseling program that I mentioned. So please, if you want to take advantage of that and have that free consultation, send me an email at carla@pmsf.org, and I will get you set up to have that meeting. And then the other is, let's see, under caregiver support, I just want to share real quick. We have support groups that meet every month. They're facilitated by licensed mental health professionals. We've been offering these programs for over a year. They've been really well received, and we've had over 250 families attend. So I just want to show you where all of that information lives. So with that, I'm going to close this out. I really do appreciate your time and that you attended this webinar with me. And I hope that if you have any additional questions, you'll reach out. Again, it's Carla, CARLA, @pmsf.org. Thanks so much. I hope you have a great day. Bye now.